Hello, and thank you kindly for the invitation to present today. My name is Bill Majdalany, and I'll be discussing variceal sclerotherapy, emphasizing BRTO and the different variations. We'll review upper GI variceal anatomy, introduce the different variations of BRTO and the associated inventory, and then discuss its outcomes. The portal system in general is the main return of all of the subdiaphragmatic organs, with blood ultimately going to the heart. When the organs flow into the portal system collects this blood and returns it in a low pressure manner to the liver. If the pressures are elevated, portosystemic shunts may develop, and these are communications between the portal and systemic veins that bypass hepatic sinusoids or other areas that may reflect increased pressure within this low pressure system. We're going to focus on gastric varices when we discuss variceal sclerotherapy, and in particular, the shunts that we're going to focus the most on are going to be gastrorenal or splenorenal shunts. If I could just distinguish what varices are as well as the gastric variceal system. Varices are submucosal dilation of the venous system. The gastric variceal system can be looked at as a gastrorenal shunt, which is a communication between gastric varices and the left renal veins. And these are an intermediary between the splenic vein and the left renal vein. Or a splenorenal shunt, which is a true communication just between the splenic vein and the left renal vein that does not involve varices or a component of the stomach. And you see them depicted here, where a gastrorenal shunt has a splenic vein going up to these varices submucosally in the stomach, with blood then ultimately going to the left renal vein. So we go from the portal system and the afferent side to the organ, and then to the efferent side into the systemic circulation. And the splenorenal vein doesn't go into the stomach. There are no varices, and it's just a direct, and it may be a meandering communication, but it is direct ultimately to the left renal vein. So when we look at the anatomy when it pertains to gastric varices, and we look at BRTO, the RTO component is a retrograde approach to the gastric varix, which means that we're going from the systemic side backwards into the portal side. So to understand how we do this, it's really important to understand the afferent and the efferent components of gastric varices. The afferent components of the gastric varix are going to reflect backwards flow from the portal vein, and generally are going to be from the left gastric vein or coronary vein, short gastric varices, or the posterior gastric vein. And you see them here depicted angiographically. The efferent veins are the ones that are going from the varix back to the systemic circulation. So this is ultimately how we're going to get to the varix from an RTO approach. So the efferent veins are going to generally go from a gastrorenal approach from a procedural standpoint, but you could conceivably potentially approach them through enlarged pericardiophrenetic, azygous, or hemiazygous communications with the IVC. Those are much less common. So before we talk about BRTO, let's talk about BATO. So BATO is the antegrade approach to transvenous obliteration, or variceal sclerotherapy. So we're going to, when we perform a BATO, target the varices from the portal inflow. So this portal flow is actually going backwards and into the varix and then over to the systemic circulation, as we just said. So we're going to enter the portal system either from the liver, from a transhepatic or transjugular approach, or the spleen. And we're going to target the varix from one of those inflow veins, whether it's the gastric vein, short gastric vein, the left gastric vein, posterior gastric vein, etc. And then we're going to ultimately embolize and or sclerose it. And here's an example of a BATO. You see in this case that we've had a transjugular access into the portal system, and we're doing a portogram, and you see a tremendous complex network of varices here. So in an attempt to control the flow, we've inflated a balloon at the inflow, and in this case it was the left gastric vein, and we're starting to inject sclerosant as well as gel foam here. We then start putting coils as well as plugs to further embolize this inflow. And when we're done, we deflate the balloon. And this is our completion splenoportogram here showing eradication of the dramatically enlarged variceal network. And we've also performed the TIPS in this case to control the outflow of the portal system. BRTO is a retrograde approach to balloon occlusion and transvenous obliteration. So we're going to target the varices, in this case, from the systemic outflow. So we're going to either come from the femoral vein or the jugular vein. We're going to get into the gastrorenal shunt. We're going to inflate a balloon, and then we're going to sclerose the varix up until we see the afferent inflow. That's how we'll know that we have destroyed the entirety of the varix. So here's a depiction with a balloon, and then we inject sclerosant to fill the varix. Generally, my preferred agents when I do BRTO in the US is sotradecol 3%. That's our sclerosing agent. I mix that with lipiodol or thiodized oil, which is the contrast agent, as well as air in a ratio of 3 to 2 to 1. And you get a white foamy solution. If you want to thicken it, you can mix it with gel foam. And traditional BRTO, when I was in my residency, we would see these large varices, of course, on CT. We would catheterize from a femoral approach in this case, and then getting into the efferent gastrorenal shunt, inflate a balloon, define the gastrorenal shunt, and then inject the sclerosant mixture that I just discussed. We then wait 6 to 12 hours with the balloon inflated. It was either a Fogarty balloon, a Berenstein balloon, etc. We'd watch the patient and then bring them back for a second procedure where we would deflate the balloon and ultimately remove it. Now this obviously delays, prolongs the procedure, exposes the patient to morbidity, and stresses the hospital. So more recently, people have developed accelerated BRTO, where we, rather than having a Fogarty Berenstein, approach the BRTO with a balloon guide. This gives us better access and allows us to keep the sclerosant in place. And in that single procedure, we inject sclerosant and then either complete the procedure at the same time by putting in plugs, so we call that parto, or coils, and we call that carto. And you see here we have the balloon and then we inject coils. We can then immediately deflate the balloon and remove it. Some people prefer to embolize with coils or plugs first, then inject sclerosant, or others sclerose first and then put the coils or plugs, and that's called front loading or back loading, and I'm going to show you examples of both. And here's going to be an example of a backloaded carto. We see varices here in the stomach, and we've approached them from a transfemoral approach. We've inflated a balloon, we've injected contrast, and we've filled the varix in retrograde fashion. So we are performing a BRTO at this point, and we see the afferent inflow from multiple feeders. We then inject our sclerosant, and as that sclerosant settles, you start to get this speckled appearance within the varix. We then start putting in our coils to perform a carto. We then deflate our balloon and remove it. And this is the completion image fluoroscopically. We then took the patient, did a non-contrast CT, and you see filling of the entirety of the varix, as well as some of the afferent inflow into the varix, completely treating it in this patient. Here's an example of a backloaded parto. So again, a transfemoral approach, we put a balloon, we inject contrast. In this case, we see the posterior gastric vein filling here, which is the afferent inflow to the gastric varix. We inject our sclerosant, you get the speckling within and throughout the variceal network. We then inject multiple plugs, deflate our balloon, and we again complete the procedure. So what's really important about doing backloading, in my opinion, is that it's non-committal. We see an extensive network here of varices. We can inflate the balloon at different areas and assess where we want to inject sclerosant. because as these networks enlarge, they can be quite complex. There may be multiple efferent and afferent vessels that you have to mitigate. In this case, you see enlarged cardiophrenic veins. We ultimately coiled these. We see other networks that are returning blood to the kidney in other ways. We coiled those off as well so that we didn't have spillage of sclerosant into other areas or have non-target sclerotherapy. We then treat the system in its entirety. We're performing a CARTO. We've injected coils here in the inferior phrenic, and then we put multiple plugs and we formed a backloading PARTO, plug-assisted retrograde transvenous obliteration, after embolizing other areas with coils to prevent non-target sclerotherapy. And you see a completion non-contrast exam here with very high dense sclerosant within the whole network, filling the afferent component, the gastrorenal pool, as well as the efferent component, as well as the whole gastric varix. So the backloading RTO is really my preferred approach. It's a single access. We do everything coaxially, usually through a 9 or 10 French system. It's easy to reposition the balloon. You can use any sclerosant concentration, and you can reposition the balloon until you have eliminated, filled the varix in its entirety and eliminated it. But the challenge is you have to find this inventory. You have to find the balloons that are compatible with your sclerosants as well as the shunt size, and they have to be readily available so that you can treat patients that may be bleeding. Let's quickly talk about front loading as well. In this case, you see a very large varix. We approach it similarly, transfemoral approach here. We put up a balloon and we fill the varix with contrast. We see that we're filling it quite nicely. But in this case, we put the plug first and then get a second access into the varix. Here we've also embolized the inferior phrenic vein. And the beauty of this is that irrespective of the balloon size, availability, having to deflate it, etc., we've already embolized it. Once we've confirmed that we're treating it, we can show that the shunt is successfully embolized. We generally use a thicker sclerosant, fill it in its entirety, and we're done. And you see a completion image here. Now the downside here is that we've already committed the embolization, so we have to complete the sclerotherapy. Otherwise, we've lost our ability to treat the varix. So that was a front-loading PARTO. This is a front-loading CARTO. Again, you see gastric varices here in this coronal image. We access the gastrorenal shunt, we coil it, we have another catheter beyond it already. We then fill the varix in its entirety, and we have completed the procedure. The consequences of BRTO ultimately are that we intentionally lose a natural portosystemic shunt. So these portosystemic shunts are redirecting portal flow into the systemic circulation and serving as a conduit of decompression. So similarly to a TIPS, these portosystemic shunts are also bypassing the liver's ability to detoxify. So if you eliminate them, you're going to reduce encephalopathy. This is something that you'd want to do, particularly if a patient's encephalopathic. And because we've eliminated the portosystemic shunt, it's going to redirect flow towards the liver, and generally this is either going to preserve hepatic perfusion, potentially induce hepatic hypertrophy, and preserve hepatic function. So in a patient who has poor liver function, an elevated MELD, encephalopathy, etc., these are potential indications to look for BRTO as a treatment of a gastric varix. The downside of BRTO is generally related to pressure. Because we've eliminated this decompressive shunt, portal hypertension will worsen in these patients. What does that mean? That means that other varices could worsen, particularly esophageal varices. So you could have esophageal variceal bleeding as a consequence. portal gastropathy may worsen, ascites may worsen, and splenomegaly may worsen. So all of these things have to go into the assessment of whether or not BRTO is the best approach for a patient or not. Just looking at some of the results of BRTO, I chose some of the papers that are a little bit older, approximately 10 years old or so, to discuss its evolution of how we use it and what its potential upsides are. When we look at bleeding gastric varices, some of the original papers came out of UVA, and at least in terms of the US. And the BRTO, initially was described as effective in obliterating bleeding gastric varices with good short-term outcomes. Really important to know that. The short-term rebleeding rates, they compared to BRTO with TIPS, and essentially, if the BRTO was technically successful, the rebleeding rates were at least equivalent to TIPS in the short-term management. What's also really important is when we look at what TIPS offers in terms of gastric varices, performing a TIPS to decompress the portal system does not necessarily eliminate the gastric varices, and including embolization with only coils or plugs similarly did not eliminate the gastric varices. So we know that BRTO can eliminate the gastric varices, can obliterate them, that it can perform equivalently to TIPS in regards to bleeding gastric varices, and that TIPS alone, while decompressing the portal system, does not eradicate the gastric varices, even when combined with variceal embolization. But when you combine TIPS with BRTO, there is a clinically meaningful trend toward reduction in gastric variceal rebleeding. So, to me, the takeaway is that BRTO is very effective in gastric varices, in eradicating gastric varices. If it needs to be combined with TIPS, it's generally a patient who has baseline very high portal hypertension, may have esophageal varices, may already have ascites, etc. But in the patient who cannot get a TIPS and has isolated gastric varices, or only has gastric varices, BRTO may be advantageous in that situation to eradicate the gastric varices. So hopefully I've reviewed with you that BRTO has evolved, and there are many effective variants. It is very much dependent on inventory. That includes balloon guides, sclerosants, and I've discussed the sclerosants that we most often use in the US. Gel foam is also very effective in this setting. There are sclerosants that are also not available in the US that would also be effective. And the shunt size itself really can guide the technical approach, but ultimately there's a way to do it irrespective of the balloons if necessary, but understanding what inventory you have and matching it to the shunt will necessarily lead to the technical approach that you want to use. So things I think about when I'm considering whether or not to do a BRTO or variceal sclerotherapy is the anatomy of the portal system. Is it patent or not patent in this particular patient? What is the inflow and the outflow for the varix? Is there an approach that doesn't require transhepatic or transsplenic or trans-TIPS approaches, which would be a BATO? Can I approach this from a systemic vein, whether it's femoral or jugular? I also consider the patient's liver function. So I think where BRTO really shines is in that patient who has isolated gastric varices, a patient who has an elevated MELD, maybe that patient who cannot receive a TIPS. This would really be a preferred approach for a bleeding isolated gastric varix. The patient who has encephalopathy and you want to treat the varix and then potentially consider TIPS in the future if needed. A patient who has poor cardiac function and cannot tolerate the elevated pressures that a TIPS would necessarily put on the heart. variceal sclerotherapy would still be very effective in treating the varices. So hopefully I've showed you several different approaches, both from the antegrade as well as retrograde, and different variations and rationales for how to do that. And with that said, I will defer any additional time I have to Q&A as well as to the panel. Thank you so kindly. It's my pleasure to be here.